Welcome back. Today we will talk about classic NBME setup. A patient came to you with newly diagnosed hypertension. Start on a first-line medication, and he comes back 2 weeks later with a rash on their face and arms after playing golf. What is the trap here? Student might think this might be allergy or lupus. The reality is this is photosensitivity from a thiazide diuretic, usually hydrochlorothiazide or chlorthalidone. The key is thiazides are sulfonamide derivatives. If a vignette mentions a sulfur allergy like to TMPSMX, students hesitate to prescribe thiazides. On the board, they want you to know the structural link. Thiazides equal sulfur. That's how you recognize this connection. With but this photosensitive rash is just the opening act. We have thiazide also causes hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, and hypokalemia. So why hypokalemia? Because thiazides directly block the sodium chloride co-transporter at the distal tubule. This means more sodium gets delivered downstream to the collecting duct. Aldosterone sees this extra sodium and trade it for potassium. The patient will lose potassium. So you can expect to see muscle cramps, weakness, or U waves actually on the EKG, which is classic for hypokalemia. For hyperkalemia, we know that there is a T wave, tall T waves, and stuff like this. But U waves is classic for hypokalemia. For hyperglycemia, thiazides actually impair the insulin secretion from the pancreas. Not ideal if your patient is diabetic. So in diabetes, we will discuss that ACE inhibitor is the first line. Why it causes hyperlipidemia, it increases both LDL and triglycerides. And yes, it causes hyperuricemia. So thiazide actually decreases the uric acid excretion. So patient starts BP meds and suddenly has a acute gouty attack. Why thiazide? This is classic question as well. And hypercalcemia, unlike loop diuretics, which wash out your calcium, thiazide increases the calcium reabsorption in the distal tubule. If you have hypertensive patient with osteoporosis or recurrent calcium kidney stones, thiazides are actually the treatment of choice. You can kill two birds with one stone. So with ACE inhibitors, picture you have a glomerulus, you have the afferent arteriole bringing blood in, the efferent arteriole taking it out. Angiotensin 2 normally constricts the efferent arteriole to maintain the pressure and filtration. So when you give an ACE inhibitor, you block this constriction, the efferent arteriole dilates, and the GFR is gonna drop. So in a diabetic patient, this is actually good. You lower the glomerular pressure, it protects the basement membrane and prevents the diabetic nephropathy. ACE inhibitors are the treatment of choice in diabetics. But you have a trap here. In a patient with renal artery stenosis, especially bilateral, the kidney relies on that angiotensin II constriction just to keep the GFR alive. You take it away with ACE inhibitor and the GFR crashes. Creatinine spikes immediately. So old patient starts lisinopril, comes back with creatinine of 3.5. Your answer would be bilateral renal artery stenosis. All this is also critical that ACE inhibitors are teratogenic. They causes renal dysgenesis and oligohydramnios in the fetus. So 30-year-old female with hypertension who wants to conceive, what do you switch her to? We will switch her to labetalol, methyl-dopa, or nifedipine. Never an ACE inhibitor during pregnancy. And one side effect here is we have the dry hacking cough. Why? Because we have the buildup of bradykinin. If they develop this, we have to switch to an ARB. But there is a critical rule for this. If they had angioedema on an ACE inhibitor, we'd never give them an ARB as well. Angioedema will recur. This is a contraindication. Then the biggest thing we is beta blocker. Beta blocker. Uh, a patient has both hypertension and asthma. Which beta blocker do you use? We will use non-selective, like propranolol or nadolol. It blocks the beta 2 receptors on the bronchial smooth muscle. No beta 2 stimulation means no bronchial dilation. Results leads to bronchospasm. So Vignette will say the patient has an asthma attack after starting BP meds. You will see. The fixes, we can give cardioselective beta blockers, the one that block only beta 1. They include atenolol, metoprolol, esmolol. That's we can give them. The one trap here is diabetes. Beta blockers can mask the symptoms of hypoglycemia. So tremors, palpitations. Diabetic comes to you on insulin, passes out without warning. Why? They're on beta block. The body couldn't send the danger signals, and that's it. And third is they can worsen the peripheral vascular disease. So if your patient has claudication or peripheral arterial disease, you have to think twice when you give this. Calcium channel blockers, they are the great first line agents, amlodipine and nifedipine, but they have the signature side effect like peripheral edema in the legs and ankles. Why? Because they cause precapillary vasodilation. Patient starts amlodipine, comes back with swollen legs. Don't stop the drug. Add an ACE or ARB instead. This actually reduces the edema, but recognize this pattern. We have one side effect specifically with nifedipine. It's gingival hyperplasia. It also happens with the phenytoin and cyclosporin. Here's where it gets interesting. So, what if a patient is on 3 drugs, thiazide ACE inhibitors and CCBs, and their BP is still 150/90? What's the cause here? You have to rule out the secondary causes. Primary hyperaldosteronism, it's also called Conn syndrome. You need to check the potassium if they have hypertension plus hypokalemia and they're not just on diuretic. We have to suspect the Conn syndrome. And the treatment then we add is spironolactone, which is an aldosterone antagonist. But spironolactone has a side effect. It causes gynecomastia. Why? It blocks the androgen receptor. So if your male patient develop this, we can switch them to eplerenone, which is selective for aldosterone receptors and doesn't cause gynecomastia. So um, we BP resistant to all these 3 drugs with low potassium. You have to think primary hyperaldosteronism and consider spironolactone. That's it for this episode. I'm gonna see you on the next one.